Hey GP learners, and thank you for joining me for this extra special episode where I'll be talking about the COVID vaccination DES and basically just going through the documents that we have so far to try and explain what you may need to think about if you're looking at completing the DES from primary care perspective. Throughout this, I'm going to be having a look at the documents that have been released by NHS England and also making reference to other documents. And make sure you join us on Saturday, where we'll be at 11 o'clock, we'll be going live through the actual DES in more detail with Andy and potentially a couple of other people again, so we can actually look at it properly this time rather than speculated as in terms of how this may be achievable for you, your practice, your patients, as well as some of the key factors that need to consideration before practices decide whether or not this is something they want to pursue for their area. In terms of looking at the particular documents, so they are available on the NHS UK website and things, and we're going to have a look at those as we talk about the various different aspects. There are 4 documents in total that we're going to go through, and I'm going to try and cover them as briefly, succinctly, but as enough depth in terms of trying to have a look at what we need to cover. In terms of it, I'm going to try and avoid giving you my own perspective, although I'm pretty sure some of that will come through at times. But at the same time, just trying to list out the key factors you need to be aware of. So feel free to join us as we have a little look, and let's get started, shall we? So I'm just going to bring up my screen share, which actually looks at the various documents that we've got to deal with. Give me 2 seconds to switch this over. And here we go. So as I mentioned earlier, you can access this information on the website at the NHS UK website. And effectively, when you go to it, you'll see that there's various different documents. There's 4 letters in total. There are a lot more. This is just a list of all the regular updates that NHS England are giving, but it's the top 4 that you need to have a look at, which is firstly the initial letter. Secondly, it's Annex A, which talks about the specifications and particularly the finance aspects of things. Annex B, which talks about the site designation elements that you need to be aware of. And then the 4th document is the one that talks about the extra £150 million that's been made available to CCGs for general practice to use in order to try and to help achieve the workload that's in the COVID vaccination DES. In terms of the first letter itself, so if we have a little look at that, so that's just a letter that opens up here, and this lists the main headline points. So if there's one part that you're going to have a look at, this is the key one. It lists most of the key factors that you need to be aware of. In terms of having a look at it, it talks about various different aspects that you need to be aware of. So it talks about building on the fact that existing vaccination programs in general practice that already exist, obviously our flu campaign that we've currently been doing, that this has been approved by the GPC, and that if you want more details, look at Annex A, which focuses on the actual specifications and things, and lists what Annex B does in terms of the site specifications. Key timelines that you need to be aware of. So it does mention in this document about the fact that by Tuesday, the 17th of November, practices need to have decided whether or not they'll be signing up to the DES, and in particular, nominating a particular site that they will be using in order to manage vaccinating patients from. Once that information has been submitted to their local CCGs, the CCGs will then have a 48-hour turnover period to try and look at these, and by the 23rd of November, have to nominate these sites to NHS England, at which point then they will reevaluate things to figure out if those are the best opportune areas for people to use as sites and things. It also lists in terms of the funding guarantee of QOF that has previously been mentioned. And a key word that it talks about is using PCN groupings. So this is not necessarily that each PCN itself has to deliver this care. It can be done by groupings of practices, and that can be within their own PCN, or it can also include other practices outside of their PCN. And in particular, we'll talk about that for a couple of things, particularly for those practices that are not part of a PCN as well. There is the element of aligning themselves with a PCN grouping. So be clear on that point. It does mention that there should only be one site per PCN grouping unless there are exceptional reasons for that to happen. And the main one it cites is about if you are covering a population greater than 100,000 patients. It also mentions within this letter about the fact that this service will need to be delivered 7 days a week, 8 till 8 o'clock in the morning till 8 o'clock in the evening. And it does also state including bank holidays. I must admit that's probably one of the most contentious parts about that aspect of things, but we'll come to that, shall we? Additionally, it further comments about the fact that vaccinations must be given in batches of 975 jabs. So effectively, this is what we understand to be because the vaccination itself comes in vials of 1,000 doses, and therefore to try and minimize the impact in terms of wastage, as well as making sure that the supply chain can work, because we all know that there are significant challenges with the supply chain for this particular vaccine. that actually the network sites need to be committing to deliver doses of at least 975 vaccines per week, and actually in batches of 975. So it would be nice to have clarity in terms of, does that mean you can give 1,500 vaccinations, for example, in a week or not? How will that work? It also makes clear that payment is based on reaching that number of 975 jabs. In terms of who's going to have the vaccinations, it lists about the fact that this is in line with the JCVI criteria, which seems to be suggestive that this will follow the flu vaccination criteria, but also we're awaiting official confirmation of that. In terms of it, then lists some of the basic stuff about the national recall system that's going to be set up to try and support this, but also that practices and areas will have to look at having a local recall system as well, unless they are planning on joining the national one, which may have additional requirements in terms of doing so. So just to be aware that there is potentially additional work if you're planning on using the national recall system. It does also mention that patients need to have all their vaccinations done at that particular site. So there is an effort to try and avoid patients from going from one particular site to another, but that patients must be offered choice of where they go to have their initial vaccinations. And there is suggestion that this will prioritize to be done in the local practice area. And it does also mention about focusing on your workforce. That the envisaged element of this is that the workforce for this will come from general practice and primary care, but that you can use additional resources in terms of volunteers, as well as bring back GP and GP returner schemes and stuff as well. And there is also commitments in there to try and have support from the wider area, including CCGs and ICS criteria. It also mentions about the payments for the vaccination, and I know this is an area that's caused many consultations in terms of local stuff, in terms of effectively £12.58 per vaccination given, and details which come in Annex A in terms of the exceptions if a patient can't have the vaccination. So this is a slight softening from what was originally in the speculated des. Initially, it seemed that you would only be paid if you gave the second jab point blank. However, it does appear that there is some more detail about the exceptions in terms of if patients only have one vaccination. But it does still state that you will only be paid once you've been given the second jab, unless an exception is applied. It does also suggest that you can repurpose elements of extended hours and extended access as well to support the delivery mechanism of this. And that is pretty much the first letter. So as I mentioned, if you wanted the headline details, it is all pretty much in this letter, as you can see here. I think it's important to at least have had a read of this one. I appreciate it is approximately 5 pages long. It took me some total of about 10 minutes to read the whole thing in detail. So I would recommend having a look at that, and I will put the links down in the show notes if you want to access that directly. However, what is clearly more important is having a look at the more detailed specifications. So we're going to do that right now, having a look at letter Annex A. So this is the indicative enhanced service specification for the COVID-19 vaccination program 2020-21. And in terms of this document, it's a bit longer. It's not too bad when you compare it to certain other documents we end up having. I mean, if you compare this to PCN DES and various other similar documents, and this is actually considered short by that criteria. There are 9 sections in total, but the 9th one is just basically confirming that you'll follow getting information from NHS England. So 8 sections in total that have relevance, I think, for practice and stuff. The first one does talk about the eligible cohorts, and in particular, like I said, this seems to align itself to the JCVI instructions about the flu vaccination. So 1.1 in particular mentions about a focus, however, on looking at care home staff, staff within practices, and the 50 pluses in particular. Section 1.2, there we are. In terms of patient choice, that is specify that patients should have a choice in terms of going to where they want to have their vaccinations, unless there's a significant reason not to do so. So, for example, if a patient has actually moved out of their local area, for example, moved into another PCN grouping area, then that's potentially an exemption in terms of how that works. There are various other sections. I'm not going to cover all of these in detail. I'm going to highlight, I guess, the key ones that, from my perspective, are going to be relevant. So if we're then looking at section 1.4, it identifies the key aspects of how practices can vaccinate their own staff and how that will work. But also, in addition, that there needs to be an agreement that is signed by practices that allows them to vaccinate patients and also members of staff from other practices as well. And this is to cover the indemnity aspect of things. So that template of that agreement is apparently being developed by NHS England and will be released in due course to help support that. And that could be amended to take into account local factors and things. But that document is pending still at this point. What it does specify and make quite clear is that all this vaccination work should be covered under the CNSGP or the NHS Resolution Scheme in terms of vaccinating patients. I guess what's not clear is in terms of the CNSGP is designed to deal with complaints once they have been made. There is the concept that many people do worry that complaints will be made unofficially in terms of before they get to that level. And at that point, how are those issues dealt with? And that's potentially a lot of workload that may have an issue that people will have to look at. In terms of section 1.5, this focuses on the fact that CCGs should be helping to make provision for vaccinating homeless patients. And in terms of housebound patients, which is section 1.6, this clearly identifies that the view is that general practice will be focusing on delivering a lot of the vaccinations for care home and housebound patients in particular. And that doesn't mean that it has to be the practices themselves. It can be leaning on their primary care colleagues as well. So I'm guessing things like district nursing and stuff may be applicable. Obviously, the key element with housebound patients is going to be the 15-minute observation period and the potential risk of reaction in terms of how that works. So potentially having to carry around adrenaline and various other stuff in case of a reaction. Key factors to be considered, I think. Section 2.1 then talks about the collaboration requirements in terms of the first part of focus is about record sharing and how that's going to work across various different areas. I think it's a challenge. He talks about reporting activity about stock, call and recall elements, staff deployment, that there's certain agreements that need to be made by networks and practices that agree to deliver this in terms of how that works and the information that needs to be fed back to NHS England. It then also talks about the agreement that needs to be signed that I mentioned earlier, and also the record sharing that comes into play with that agreement and things. And it just lists, I guess, key things that many of us would understand would have to be there in terms of sharing of information across organisations and stuff. I would hope a lot of that's been dealt with in terms of the data protection and etc. And all that should be covered in the shared template agreement that is sent through by NHS England. We hope so. The next section talks about the designation in terms of the site area. So this is it simply signposts you to Annex B. So we are going to have a look at that now. So this is Annex B. It's 13 pages long, so it's not short. And there are key areas that you need to be aware of when we're looking at this document itself. So I'm just going to briefly scroll down. The initial part is about quality and diversity assessments, etc. and things. And then it talks about some of the key information that's already in the initial letters. It does set out the requirements for different categories of areas, so practices, CCG teams, as well as NHS England, NHS Improvement, and what each relevant team will have to do. It also recognises the complex elements of the logistical aspects of delivering this, so being aware of that. It does also comment about how to go about looking at the vaccination sites and some of the key information in terms of that one site per PCN grouping and not having a second site unless there's over 100,000 patients that need to be covered, but potentially later on in the schedules in terms of how this may work post, I'm imagining post-Christmas, that there may be additional sites that could be approved at that time, but at present this area is key. It talks various other aspects, so in terms of designated sites to continue once the designation criteria has been approved. So basically, not only do you have to obviously achieve the designation criteria at the start, you need to make sure they keep doing that. And if there is a change to the site, then that needs to be made aware to the various people. In terms of timescales, it relists the timescales that everything needs to happen, and they are short. Let's be clear on that point. In terms of the process itself, so let's have a look at this. It mentions on 3.2 that the premises must be ideally within the control of the practice. So I guess this is one of the key things many people are talking about. Can we use other venues and that kind of thing? So churches, I know have been mentioned, football stadiums, etc. It does specifically state in 3.2, it is expected that PCN groupings will possible use existing premises within their collaborating practices control. It does also state that obviously if that's not available, then that may be shared across other network areas. But I guess that's a key part I would mention signposting too in terms of having a look at. In 3.3, it talks about how where are we? the minimum requirement of vaccinating 975 vaccinations per week. So that's important again to note. I'm going to scoot down to 3.7 because the rest of them talk about the deadlines and timelines and other things with CCGs. It does mention here that, and this is a slight one to take note of in terms of 3.7, which is why I'm guessing it's been bolded out, that even if networks and practices were to nominate a site that they felt was appropriate, there is still the possibility that may not be approved by NHS because it needs to take into account other factors such as access to the area, such as equality of access for other people, various other factors that they will consider once the submissions have been made. I guess that kind of makes this recommendation that you may have to consider having a backup site in terms of looking at your plans. So just to be aware of that particular one, it's bolded for a very good reason, I think. So to be aware of that. It then talks about like those criteria and then further information until we get a bit further down. Where are we? So Annex A. So the annexes itself talk about things like storage in terms of that you need to have a fridge that can store the vaccines at 2 to 8 degrees and be able to store 975 doses. I think one of the key things here is understanding what on earth 975 doses looks like and how big a fridge we're talking about. If this is just a vial where you draw them up as you use them, then that's potentially a lot less space than storing 975 pre-made vaccines, which obviously come with all the paraphernalia and packaging that come with that. That's a completely different situation and a completely different number of fridges you will need to have in order to do so. Obviously, there will need to be the various monitoring requirements as per usual with temperatures and thermometers and all that kind of stuff to make sure that the temperature has been maintained at 2 to 8 degrees and things. Also, you will need to have storage for all the consumables you'll need, PPE, etc., along those lines as well. In terms of planning coordination, it talks about various other aspects. So we've got about reconfirming that you have a site that's available 7 days a week, 8 till 8. And also, where are we? 2.5 was the next one. Ability to accommodate new vaccine types as they become available. So there is a possibility that all this could change if the vaccine criteria for later vaccines is different. So being aware that we are signing up to that. Next section, 3.1, site safety. It looks about having a smooth entry and exit for patients, and in terms of social distancing elements and stewards and parking. I guess one of the key things to consider is about security. There are concerns that there may be issues in terms of either people trying to steal the vaccine or people protesting against the vaccine as well. There's no real clarity in terms of that. Section 4 looks at wastage and making sure you've got enough capacity to not only deal with the waste supplies. And I guess there are some questions about the recombinant DNA elements of some of the vaccines, RNA of the vaccines, and what type of wastage criteria that fits into. And the cost of that, there is no clarity in terms of how that works, but I'm assuming that's to be covered within the pay envelope of the vaccine itself. And then the ability to plan that you shouldn't be wasting more than 5% of the vaccine itself. The later sections talk about space, the physical layout that needs to support the plans. Again, there's no detail in terms of that. In terms of workforce, it talks about having a lead employer element and how that works in terms of registering staff and also administering the vaccine. And yeah, just a bit more information as to what we need to look at from that area. Section 7 talks about the patient experience and also making sure you've got enough information, etc., available for patients to be aware of what's happening, signposting information, for example, and providing information online. Key in one, I think that's somewhere when NHS can actually take the lead with and support us. So we've got standardized information available to everybody. It does mention about making support for those with additional needs, I guess particularly the learning disabled patients, non-English speaking, for example, will be areas in terms of that. And that you will need to do an equality impacts assessment if you are using a non-practice environment. So again, if you're looking at using church halls, etc., there will need to be those assessments made. In terms of vaccine storage, that's fairly simple. We've already covered some of that information. Preparation, that you need a workforce able to deliver this. Administration, same thing, to be able to deliver it appropriately. And in terms of aftercare, this, I guess, is a key one. It doesn't actually specify clearly how this is going to work, but what it does state is that patients need to be monitored for at least a 15-minute period after having the vaccine to be aware of obviously what to do and the appropriately trained staff to respond to situations if need be. Data collection then talks about how you collect the data, I guess, and the impact of that. there is lots of questions of how this may work in terms of using practice systems and the type of information that needs documenting. That is listed in Annex A in more detail, but to be relevant along those lines, and the fact that you need to commit to reporting towards the various entities and organisations above this. So that's section 3. I'm going to go over to section 4 now, which talks about the call and recall system that's potentially going to need to be developed. I mentioned this earlier, that there is going to be a national system that's available, but actually you will need to potentially have your own local version as well. So whether it's using practice systems or other kind of systems to help support the local call and recall, if you were to use the national systems in terms of the booking service, then there is potentially additional requirements in terms of what you may need to do to comply with that. It does mention that about focusing on using general practice resources to help in terms of sending letters and texts and stuff to patients to try and get them on board, but being aware of that. Section 4.3 talks about using national extraction to get the information as to who's had the vaccinations. There's no details on the codes as of yet of how that will work. That will be really important, obviously. Section 4.4 looks at, where are we? Or if patients don't respond, that they can return those patients to the national program if the uptake is low, but there will be a push as well to try and make sure that all the vaccines are used appropriately, and potentially to proactively reach out to patients if there is low uptake and things. Again, no detail in terms of what that means. I mean, does that mean we're going to have to be visiting patients? It is a question I would like to have clarity on. So 4.4 is a key one for me, if I'm being honest. In terms of how ordering, so that's talked about, and making sure there's no wastage. In terms of booking the appointments, again, it talks about either using local or national booking systems in terms of doing that. One key thing it doesn't mention is there's no way of knowing if patients have actually automatically booked into a national system to share that information with a practice and stuff. So there may be some duplication of work, and making sure that patients don't accidentally have additionally booked vaccination slots when they don't need them. So yeah, be aware of that. 4.7 talks about information pre and post vaccination. Again, this is all pending. There's no details at present. The consent process is the one that causes me the biggest concern in terms of how we will achieve that, because we don't have the information about the vaccine itself and how this will look. So I think being able to understand that deeper is going to be important. And then we go on to section 5, which talks about preparation and administration of the vaccine. There's very little information here, to be honest, because all of it is pending. So I'm afraid we don't know is a simple answer. And that's a frustration, because I guess in terms of trying to understand how to deliver some of this, we kind of need to know all this. It commits to making sure that patients follow existing guidance when it comes to delivering and administering the vaccine, such as similar that created by the JCVI. And in terms of, clarifying that it identifies at least 7 days between flu vaccination and having a COVID vaccination. That's re-emphasized in section 5.9. In terms of workforce, it does talk about who can administer the jab. It specifies that this can be any registered healthcare professional with the appropriate training, and how that training will happen. And the requirements and stuff are then listed in the following sections. In terms of what additional workforce will be made available, again, it re-emphasises that the workforce should be coming from primary care, but there are volunteers and potentially bring back GP and return a GP schemes that you can look at. So yeah, not a great deal in that respect. Stewarding and security I mentioned earlier, so 6.5 mentions this in a bit more detail, but again, doesn't specify about how to manage aspects of security, and obviously that should be provided within the funding envelope that's made. Let's talk about funding, shall we? So that's section 7.7 and 7.1 onwards. So this is the one that specifies that the payment will be £12.58 per vaccination, which is a 25% uplift from the normal flu vaccination. So a total of £25 and 16 pence. If patients have both vaccinations, it does clarify that practices will be paid on second dosage unless a patient fulfills one of the exceptions, which is in section 7.2. This talks about the unsuitability of the patient. So if they've had an allergic reaction or intolerance to the vaccination, if they've commenced on end-of-life care pathways as in between the two vaccinations, or if they've already been deceased and died, unfortunately. It does also specify if the patient's chosen not to have the second vaccine that you will be able to claim payment for the first one. Unfortunately, it doesn't specify to what degree practices and networks will have to go in terms of confirming that. And similarly, if the patient's had no response, again, there's no detail in terms of what level that will be. I guess I view that point with some skepticism, given how QoF and etc. can sometimes work. Does that mean that requires multiple contacts? If so, what type of contacts, particularly in our COVID world? Does that include it? We're going to have to visit them, for example, which may, I don't know. It'd be nice to have clarity on what that particularly means, and hopefully we will have some of that in the following webinars that are due to happen. Also mentions if the patient moves in or from a different area, which are the last two parts, in terms of how that will work. So, for example, if the patient's in one network grouping area and moves to another, neither what network will be penalised for the fact the patient's only having one vaccination. Will there be additional sources funding? Simple answer is no. There are a couple of minor exceptions to this. So it mentions about how additional costs should be sourced and supported by the CCGs in terms of venue, for example, and also that there may be some funding available for fridge capacity in terms of if a significant extra fridge capacity is needed. Again, no detail on that. It does, however, confirm that dilutants and the equipment for dilutants and needles, etc., will be covered and provided for practices in order to administer the vaccination. However, and also with PPE, but that's through the portal, doesn't comment on cleaning equipment or other consumables that may be needed in order to run these clinics. And for example, the pads for defibs, the medications for emergency use and stuff, none of those are covered within that as far as I can tell. How will practices be paid? The details aren't clear. That's really frustrating. We don't know how we're going to be paid. Section 8.1 talks about documentation of the vaccination, and these are things that you would typically expect. So vaccine type, batch numbers, site of vaccination, person drawing it up, person administering, those kind of standard pieces of information that we would expect anyway. This hopefully should be done by a template, I would imagine. And then finally talks about reporting, and in terms of if the patient's been vaccinated by another provider. That last one, unfortunately, isn't detailed, so we don't have that information. And as I mentioned, the last part of Annex A is talking about practices must sign up to have the updates from NHS England if they are planning to do this, which kind of makes sense. So that's the DES in detail, and hopefully that's covered most of the information aspects you need to know about it. In terms of the final part that I did want to talk about was the letter that we've also received that talks about the additional £150 million made available to GPs in order to help deliver this. This is to recognise the fact that this is going to take us away from our normal workload, and therefore in order to help expand the capacity that's available in primary care, there's additional funds available. This has been split according to your CCG area. So, for example, for my local CCG in Nottinghamshire, that's a total of 2.7 million that we've been allocated out of the 150 million. Key things to recognise about this is there is additional financial support potentially available in the source of recruiting, deploying GPs on the basis above, and that's a total of £120,000. I'm assuming that's nationally. I couldn't quite understand that one. And support with developing contracts, for example, to help support things. But there are expectations, so not requirements, but expectations of how this funding will be used. There are 7 in total. So whilst many people will be talking about the fact that general practice has only been given another £150 million to use, it is in some ways restrictive because there are expectations of how this will be used. The 7 criteria: increasing GP numbers and capacity, supporting the establishment of simple COVID oximetry monitoring models, such as used in care homes and things, identifying and supporting patients with long COVID, continue to support clinically extreme vulnerable patients and maintain the shielding list, continue to make inroads into the backlog of appointments, including chronic disease management, routine vaccinations and immunizations. I'm assuming that means in primary care, not in secondary care, because this money is designated for primary care use only. On inequalities and tackling particularly one of the key ones it's looking at is the learning disability checks that is a key requirement that they continue to maintain that this should happen. That clearly sounds sensible because these are a vulnerable group, but it does mention that particular group specifically, and also potentially offering backfill for staff absences where it's agreed by the CCG, so supporting I think some of the absences that may have to happen unfortunately because of isolation or COVID or other health reasons in terms of maintaining workforce. So those are the 7 criteria. So this doesn't mean we're suddenly going to have money for an additional workforce. And in terms of how that works, this is, I guess, designed to try and support existing work, not to pay for the delivery of the COVID DES. That's meant to be done within the envelope of the money that's already been provided. I think in terms of looking at this, there is obviously a lot of information taken to board, and I hope that this session has been useful in terms of explaining that. As I said, in terms of looking at more detail of how this may work, feel free to join me on Saturday at 11 o'clock. So that's Saturday the, where are we? I've actually forgotten. There we go. That's not so good, is it? Saturday, the 14th of November, where myself and Andy will be talking about how you can look at this DES for your local area to tackle things and hopefully figure things out. Apologies, it's going to have to be Saturday. It's the first time both myself and Andy are available to look at this in more detail, but we promise you that we'll have really good information and content to help with that. This will obviously be post the NHS England webinars due tomorrow to help explain some of this information to you. And we will also hopefully have some guests on to try and help explain some of the complexities of this, particularly in terms of the medical information that's needed, and well, some examples we're hoping in terms of how you might be able to achieve this. I know potentially we're going to be listening to the Nottingham model, for example, from our perspective. So hopefully being able to share our experiences with both myself and Andy being involved in some of the delivery of this. I hope you're all keeping well. Hope you're all staying safe. I hope this has been useful to you all. Please leave me any comments or corrections in particular. If I've made a mistake with any of this, more than happy to be corrected. And as always, EGP Learning is here to help save you and your patients time by enhancing your primary care and learning.